Hello everyone. Today we are going to be continuing about the ECG lectures, and today we are going to see the ECG waves in various different ECG lead. That's the limb lead, because in the last video we have seen the orientation of the lead. So now we are going to see the waves, because as we have already said that each lead is showing its different QRS complex, its different P wave, then T wave, each lead. So that's it. So now before we start, let us show the position of each lead. If this is the heart at the center, here we have the ABF, here we have the lead 2, here we're supposed to have lead 1, here we're supposed to have lead 3, and then here we're supposed to have ABL, and then AVR. So this is the orientation. So for example, if we take this corresponding to this heart, then we will be saying this. Here we are going to have the lead 2, here we have the lead 3, then here lead 1, then AVL here, then AVR here. So that is it. Then AVF here. So now we are going to see the direction. As we can see, here is the SA node. So this is the SA node, this is the AV node, this is the direction, because the impulses are moving in the heart in different direction, but where the heart is more thicker is what determines the average direction of the polarization wave, which is called the cardiac axis. Because here is more thicker, so most of the direction of the polarization wave is going to be moving toward this side. So it is, but this doesn't mean that it is flowing only in this direction. It is also flowing in other direction. So that is it. So now let us begin with the AVR. So as we have already know that any lead, when the electrical activity is going away from that particular lead, the lead will definitely going to show a negative deflection. When it is going toward the particular lead, it's going to show a kind of positive deflection. So if this is AVR, as we have already seen, the direction of this is going away from this AVR. This is the direction. Some are going toward the left atrium, some are going away down, so that it's through the gap junction. So definitely for the P wave of this AVR, for the P wave will going to be negative deflection, because it's going away. And then apart from the P wave, then definitely the Q wave that we are going to see in AVR is insignificant. So it's almost insignificant. And also the direction of the QRS complex, that is the direction of the depolarization of the ventricle, are also going away from this AVR. Definitely, all of them are going away from this AVR. So definitely that's why the QRS complex of AVR will definitely be negative also. That is inverted like this. Then the T wave also is going to be inverted. So this is for the AVR. For the AVR. So how about for the lead 2? Or let's say let us take the AVL. So this is it for the AVL. For the AVL, there are some kind of inputs that are going toward the AVL, right? So that's why the P wave of AVL will going to be upright. Then the QRS complex are also going to be a kind of upright, but it is going to be like very minimal, because it is going to have kind of positive QRS complex, because this is Mutika, so most of the electrical activity are going in this direction, and also this ABL is a kind of toward this side, so that's why it's going to have positive. But because it is away a little bit above the strong depolarization wave, so definitely the QRS complex is going to be short, but it is not going to be negative like the AVR. So that's why it is going to be a little bit short. So like this. So the T wave is going to also be, sorry, here are supposed to be, this is, I want to make it very short. So this is the T wave. So that is it. And then when we come to lead 3, that's lead 3. for lead 3. Then for lead 3, these are some kind of impulse that are going toward lead 3, but they are not as strong as this. So that's why we're going to have, and also if we take the P wave, they are going also toward the lead 3, this. So it is showing a kind of P wave, positive deflection. And then if you come to QRS complex, the QRS complex are going to also be positive deflection, but they are not going to be as taller as lead 2 and lead 3 and AVF, and even lead 1, because they are not as strong. Because see, these are very strong, these are very thin, so they are less strong than this. So that's why the the QRS complex is going to be positive, but very short also. So this is a T wave. So this is for lead 3, and then if we come to lead 2 also, but for lead 2, the P wave and then the QRS complex are going to be very taller than all of the limb lead. So this is its P wave. Then this is the Q wave is for the polarization of septum, right? And then septum is the one that is depolarizing first. It's not that. So it's going to show a kind of Q wave and very tall QRS complex like this. This is for lead 2. So now we are going to see for lead 1 and then for ABF. And then for lead 1, definitely the impulse are going, as we are seeing, for lead 1, the impulse are going toward lead 1. So, but not as strong as this lead 2, because see the cardiac axis is pointing directly to the lead 2. So definitely it's going to be a bit taller than this, but shorter than this and this. So this is for its P wave, and then this is its QRS complex, and then this is the T wave. This is for lead 1. And then for lead AVF, is going to have, there are so many P wave direction that are pointing toward the AVF. So definitely it will going to show a kind of good AVF, good P wave, and then there are a good depolarization wave of the ventricle also pointing the AVF. So definitely it's going to be very tall, but it's not as tall as the lead 2. So this is for AVF. This is its P wave, and then the QRS complex. This is T wave. So that is it. This is for ABF. So this is ABF lead 1, and then this is for ABR 3 and 4, then 5. This is for ABL. So 6. So that is it. So why? Let us see the. So this is it. This is AVR. You see it is inverted because all the inputs for the P wave. This is a P wave. It is inverted. This is QRS complex are also inverted because the inputs are going away from the AVR. So this is AVL, a bit shorter. This is the P wave. So this is lead 1. It is a bit tall, but it's not as tall as lead 2 because almost all the polarization wave is going directly toward the lead 2. Then this is AVF. It is also very tall, but not as tall as lead 2. This is lead 3, also upright. So that's it. So why we have to really know which one is having taller QRS complex, which one is having shorter, which one is having inverted, and this and that, because sometimes we may have a kind of axis deviation. When we say axis deviation is when this, for example, right ventricle become very thick, for example, in the case of right ventricular hypertrophy, so this strong depolarization wave are going to be shifting to this side. So if they shift to this side, so definitely this lead 3 will going to be very tall, taller than lead 2. The lead 2 is now going to be as short as the normal lead 3, and now the lead 3 is going to be as taller as the normal lead 2, because now this will going to shift to the right side. That is called the right axis deviation. So what is causing the right axis deviation is when the right ventricle becomes very thick, as like the left ventricle, or when there is left ventricular branch block. Because if there is left ventricular branch block, so definitely almost all the nepolarization wave are going to be moving toward this side, not this side, right? So this will shift to this side because no impulse are passing to this side because of the block. So that is it. So now seeing the this is the lead 2, this is the AVF. It's very tall also. So that's it. So this is the end of the lecture. So in the next video we are going to see for the chest lead, that's the V lead. They are also unipolar from V1 to V6. So that's it. So thank you very much.